Yeah. So no conflicts of interest here. There we go. So some learning objectives for this talk. First, we're going to describe the prevalence of LTBI among Medicaid recipients in King County in order to appropriately allocate public health resources and educate community providers. Then also identify the demographic factors and medical comorbidities that describe King County Medicaid recipients most burdened by LTBI, and use this information to target treatment and prevention efforts to those most at risk. So I'm sure many of you are familiar, but a little bit of background on LTBI. Stands for latent tuberculosis infection. This is diagnosed through either a skin test or a blood test. And the disease is declared latent when there are no other indications of disease. So this includes clear chest radiography as well as absence of symptoms. So some goals of the project that I've been doing is, number one, to estimate the burden of LTBI within King County. And secondly, to evaluate the appropriateness of testing and treatment for LTBI. How I did this is I looked at Medicaid claims data from 2012 to 2018. And the reason that we use Medicaid for this project is mainly just because that's the one that our data team has put together already. In the future, we hope to add in Medicare as well as other providers, but that was not something we could do right now. So in order to accomplish these goals, I pulled LTBI diagnoses based on ICD-9 and ICD-10 diagnostic codes. I also pulled people that had received testing for tuberculosis through either the IGRA or the skin test. And I mapped these with other demographic factors and comorbid diagnoses. So estimating the prevalence of LTBI is really important because treating it can prevent or can lessen the burden of active tuberculosis by preventing transition from latent to active disease. So this is just an example of a paper that looked at the prevalence of LTBI from 2011 to 2015, and you used mathematical modeling to create an estimate for every county within the country. Inside this red circle here on the left is King County, which is dark blue, indicating a relatively high prevalence of 3% or more. And my project is contributing to this body of literature on LTBI. By getting kind of a more concrete estimate of the prevalence, particularly for King County. So this table here is a little bit overwhelming. Don't worry too much about the numbers, but I just want to point out that the number of Medicaid eligible people within King County has been increasing. It's nearly doubled since 2012. And then all totaled, there were 3.7 million Medicaid eligible people that I used in this analysis. Of those 3.7 million people, about 100,000 were tested for tuberculosis. And among those, 40,000 were subsequently diagnosed with LTBI. When we look at the prevalence of LTBI, which is the light blue bar here on the screen, it has been increasing. And in 2018, the prevalence of LTBI among Medicaid eligible people in King County was just over 1%. And you can see that there's a high number of people tested are subsequently diagnosed with LTBI. So in addition to the increase in diagnoses, we also see an increase in testing, which is great, but this gives us a good estimate of the prevalence, but it doesn't necessarily tell us whether the right people are being tested for tuberculosis. So the U.S. Preventive Services Task Force has some recommendations for screening with three main factors. The first being persons born outside of the United States, who are particularly those from high-risk countries, but their recommendations just involve people born outside the United States. In addition, people that have a history of living in congregate settings, such as shelters or prisons, are at high risk of LTBI and are recommended to be screened, as are people with immunosuppression. So using claims data, as I have, it's sort of tricky to analyze all of these things. But one of the things we could look at is where people are born. So take this with a little bit of a grain of salt. This was designed using self-report primary language. So keep in mind that anybody who reported English as their primary language is excluded from this. But this was kind of what we had to work with, and is the kind of, it's a starting point at least. And what we can take away from this is that 20% of people from East Africa and 20% of people from the Middle East are being tested for tuberculosis. And those are the people that are being tested most frequently among those who are from outside the United States. Similarly, we can look at the same demographic factors among those that were diagnosed with LTBI. So East Africa was one of the places where there was a high frequency of testing, and we see that over 70% of people, of East Africans that are tested for tuberculosis, are subsequently diagnosed with latent TB. Interestingly, only 45 to 50% of Middle Easterners are testing positive, even though they were being tested with the same frequency. And then another takeaway here is that people from India and Latin America are positive about 50% of the time. But if we go back to the previous slide, we can see that those same populations are being tested at extremely low frequencies in comparison. So there's a few discontinuities here. Some other demographics we can look at in regards to testing and diagnosis, gender, age, and race and ethnicity. So what we're seeing here is that females are being tested more frequently than males. 4.5% of females are tested in the county versus 3.5% of males. Similarly, we see higher frequencies of testing in those over the age of 65 and in Asian and Black people. As far as diagnostics, males were being tested at a lower frequency, but are subsequently diagnosed with LTBI over 50% of the time. And females are receiving diagnoses at a lower frequency. Also, with regards to age, we saw that those aged 65 and older had a high frequency of testing. However, the people that are more often positive are those in the 45 to 64-year-old age range. In regards to race and ethnicity, it is pretty similar to what we saw with the demographics of who was being tested, with a notable exception of Native Hawaiian and Pacific Islanders. If we go back one slide to people who were tested for tuberculosis, Native Hawaiian and Pacific Islanders are low compared to other groups. They're being tested about 4% of the time, but they're being diagnosed positive about 50% of the time. So there's some minor discrepancies there as well. Another thing we think about with LTBI is treatment. And this is a snapshot from the CDC to demonstrate how treatment is recommended. Treatment is long, between 3 months and 9 months, which can create problems for adherence and people completing treatment. When I look at Medicaid eligible people within King County, fewer than 50% of them are being treated most of the time. And keep in mind, this is likely a large overestimate of who's actually being treated, because I was looking at people that had at least one claim for rifampin or isoniazid, but that does not mean that they completed treatment. It means that they started treatment at the very least. Other thing to note here is that the proportion of LTBI diagnoses that are being treated has been decreasing since 2014, down to about 42%. Another thing we worry about with LTBI is transition to active tuberculosis. There are some factors that can contribute to this, most prominently immunosuppression, including HIV infection, certain chemotherapy drugs, TNF-alpha inhibitors, organ transplants. A lung disease, silicosis, can also put somebody at risk, and potentially poorly controlled diabetes. Looking among the population here, the Medicaid eligible people in King County, about 1 in 5 of them have one or more of these risk factors for transition to active TB. So that's higher than I anticipated, but an important thing to note, and it's also increasing. So we're seeing in 2018, the highest proportion of people with LTBI are people with one or more of these risk factors. So if we look at how many of these high-risk cases have been placed on treatment, it's low. It's lower than actually the average of all people with LTBI, and it's decreasing again. We had a little bit of an uptick in 2018, but it's still below 40% of these high-risk cases are being treated. So in summary, there are disparities, like we've talked about, between the demographics of who's being tested and who's subsequently being diagnosed with LTBI. Also, 1 in 5 individuals with LTBI are likely to be at high risk for transition to active TB, and 50 to 70% of these high-risk cases are not treated. Furthermore, LTBI diagnoses are increasing, as is frequency of screening, which we expect. We expect to see an increase in screening with increase in diagnoses. But the problem is that since 2014, the percent of individuals with LTBI that have been treated has been decreasing, which could potentially say that we have a lack of capacity to treat these things. It could mean a number of things, but I think that's a really important point to take away. And here are my references. That's what I have. I'm happy to answer questions.